Hello, everybody. My name is Professor Stephen Brett from Imperial College in London, and I'm going to share with you some thoughts on the relationship between psychology and the physiology of recovery, which has been a research interest of our group for some time. I've no conflicts of interests, and what I'll start with is this slide from our colleague Brian Cuthbertson when he was working in Scotland. And what we see on this slide is the accumulated quality adjusted years of life after discharge from intensive care. And we can see here that the ICU survivors in the lower line accumulate QALYs, as they're called, at a much slower rate than an age and sex matched population. So there's a disparity in quality of life. And why might that be? Well, running my intensive care clinic, I've noticed over the years these factors which seem to interact to make an impact on people's quality of survival. And some of these are physical things, and some of these are very much psychological things, such as anxiety, depression, stress. This one here, perceived change in health, is particularly important, but actually continuing disease and pain and physical limitation are obviously also very important. So some years ago, with one of my research fellows, Dr. Eve Corner, we started looking at this in a very qualitative sense, and she undertook a series of interviews, which led to some important insights, I think. But these things we identified were, first of all, the importance of an interrupted story, which I'll come back to, the shock patients experience when they awake, especially when they're delirious, the realization that their body has changed very substantially, a little bit of uncertainty about rehabilitation, what it is when one is in a slightly confused state, the importance of goal setting and how that might be different in an intensive care setting to a conventional rehabilitation setting, and also the importance of motivation and self-determination and the humanization of care. So as humans, we make sense of the world by creating a sort of rolling story. And of course, for critically ill patients, sometimes their story comes to a sudden stop. And that might be because they collapse on a ward or because they decline over a period of time before they end up in intensive care, or they may go to sleep expecting an elective operation but wake up sometime later. But this loss of story, the narrative discontinuity, can be quite shocking for patients. And of course, when they're waking up in a different place, unexpected, surrounded by people that they don't know. And obviously at the moment in COVID, then people are waking up being surrounded by individuals in personal protective equipment, which must be even more frightening. But anyway, for anyone waking up in intensive care, it can be a frightening experience. And I put a couple of quotes here: waking up, becoming conscious, maybe panicked. So it's a difficult experience for people. And then, of course, physically, their bodies have changed. And for anybody that's been in ITU for longer than a brief period, then they will suffer from joint stiffness and skeletal muscle weakness, which can be striking. Nothing could move. And of course, often patients, when they're waking up, their consciousness is not terribly clear. And many people will have frank delirium, which can be very frightening for everybody and very frustrating for us as carers. That's also very important. And rather surprisingly, lots of patients were a little bit confused about mobilization and rehabilitation. And when interviewed in recovery, as in at home, they often recalled very little about the input of the physiotherapists. And also, they were a little bit surprised at what we as teams were quite pleased about. So, how do you applaud because I wash? So, things that we think of good steps forward for patients, actually they think, well, I've been doing this for 70 years. Why is that a surprise? So people's perceptions of rehabilitation may be different to ours. And then the issue of milestones and motivation is quite important. So one of the things that we learned is that patients have a mismatch between the memory of who they thought they were when their critical illness started, and then they look down and see their body or start re-experiencing their current self. And that mismatch can be quite shocking. And of course, people probably need to recalibrate their mental representation of who they are at that point in time, rather than confusing it with who they were some weeks previously, and then somehow prospect forward to a vision of a future self that they might be again with appropriate work. And this was articulated by Marcus and Nurius some time ago in a theory called possible selves, which seems to map very closely onto the experience that our intensive care patients have. This mismatch between their past self, the current self that they're experiencing in the intensive care unit, and the person that they need to be again. And perhaps we need to focus a little bit on providing people with a more solid vision of who they might be again, because otherwise it starts to undermine people's motivations because they can't see what they're working towards. This is all a little bit around goal setting. And in conventional rehabilitation, then the goal is set with the patient as a primary driver. But for the intensive care patient, often their experience is so far away from what they're expecting or what they have knowledge of that actually they need help early on to set those goals. And in fact, one of our patients conceptualized this with the bottom phrase here, like someone asking someone in a car crash how they want to be cut out. But of course, as time goes on, then we want to hand over that responsibility to the patient. The issue of motivation was brought out in a focus group that we held as part of an enhancing recovery program. And these was a group of patients and family members, and they identified that actually motivation was fundamental. And if you're not feeling very motivated or engaged, then why would you subject yourself to hard physical therapy, which may be extremely tiring and uncomfortable? And it's too easy to drift away from working. And of course, that confounding factor of motivation is not normally tackled in most of the interventional trials that we've done thus far in a critical care survivor population. So understanding how to engage people for their own benefit, but also how not to demotivate those whose recovery might be limited, is a very sensitive thing. This also maps onto a classic psychological theory called self-determination theory, published originally by Deci and Ryan, two American psychologists. And they identify that there are a number of pillars of self-engagement, self-determination: autonomy, competence, and relatedness. So autonomy is taking decisions for oneself, competence is being able to do stuff, and relatedness is interacting with people around us in a way that humans normally do. And of course, before intensive care admission, then people are autonomous, competent, and they relate to things around them. But of course, once they get into intensive care, all that disappears. And perhaps the first to recover, if we're clever about it, might be relatedness. People still won't have autonomy and they still won't be competent, but we might be able to leverage them forward by this concept of relatedness, human touch, family presence, feeling cared for and safe, maybe humor, trust in staff, but all of these sorts of things. And then, of course, autonomy and competence, some of these things are physiological, muscle wasting, ventilator dependence, etc. And then the human factors are interesting. In this column over here, communication, daily structure, dressing, urinary catheters, these sorts of things, allowing people to become independent. And a good example of this is cleaning teeth. So either the nurse can clean the patient's teeth, which takes 2 minutes, or the nurse can assist the patient cleaning their teeth, which might take 20. And we need to be careful that often we don't do the thing which seems more efficient, because that may well undermine the development of autonomy and competence. So we might divide intensive care into a number of stages. First off, we're stopping people dying, stabilization. Secondly, we might, in this sort of level flight phase, do things to improve relatedness. And then stage 3, we want to transition to a point of patient autonomy and help them forward in that sort of direction. But perhaps understanding this concept of future help and engagement may be very important. So we might divide our intensive care stay goals into 3 separate different terms. 2 papers that I'll share with you. This was a study looking at the literature on interventions to try and improve quality of survival. And Selina Parry and others produced quite a useful framework, which is in this paper. These are the sorts of things that might be facilitators and barriers to making process. I think they slightly underestimated the issue of motivation. And although they do acknowledge that psychological factors may be very important, I would argue that actually it should be in slightly clearer terms. And then more recently, Major and colleagues published this study where they looked at developing a consensus statement on the important things for physical rehabilitation after hospital discharge, and they again produce a useful diagram for us. But again, these are the sorts of interventions that they might make. But if you look at these things, they look like quite a lot of hard work to me. 80% 6-minute walk test, 75% speed on a shuttle walk test, interval training, circuit training. So this is hard work. And you can imagine that actually if the psychological status of the patient isn't where it needs to be, then the chances of them collaborating with this is going to be pretty low, and the chances of demonstrating real benefit will be minimal. So I would definitely argue that when we're looking to rehabilitate patients and mobilize them, we need to pay some attention to the psychology of recovery, because otherwise it won't be surprising when they don't really benefit from the physical therapy. And I do think that we have underestimated its importance in the past. I can't go back to yesterday because I was a different person then. Thank you very much for your attention.